Good morning and good afternoon, depending on where you are. Welcome to the World Sickle Cell Day, and I hope we have more audience and we can start now because we have a lot of things to cover. So to start with, is everybody prepared that we start now? Mr. Funsho Ore-Tayo, he's an IT specialist, consultant of system engineer. He is a sickle cell patient that we treated in our clinic, and we wanted him to come so that we can put a face to sickle cell disease and then be able to get his own perspective to us who are his providers. So on that note, I welcome Mr. Funsho to the forum.
Thank you, ma'am. I appreciate it.
I wanted you to let us know, to tell us how you came to know that you were diagnosed with sickle cell disease.
Well, thank you all for the opportunity. Thank you all for inviting me to this forum. Originally from Nigeria, I was born to a family of 5. I lost my sister 30 years ago to sickle cell. May so rest in peace. Well, what I was told was back then as a kid, I went swimming about 5 years old. And I came back holding arms and legs in pain. And, my parents were wondering what happened, what's going on. And we eventually went to the hospital, went to a clinic. We used a family clinic, a family doctor, run by Dr. and Dr. Mrs. Olasunbo. They had their own clinic. The husband, Dr. Dipo Olasunbo, he's a pathologist / hematologist. And the wife, his wife, Dr. Tokumbo Olasunbo, she's a GP / hematologist. So that was from there that we ran the blood work genotype, and they figured out that I had sickle cell, and my pain management started. Now back then, kids weren't tested from birth, for their genotype and blood work to see what they have. Is unlike here in the Western world, whereby they know from infancy that they have sickle cell. So it was from 5 years old that I knew that I had sickle cell, and that's when things changed, and I started managing my pain for sickle cell.
You led us into knowing how you felt having a disease, that you were having crisis, and how often were you going to the hospital, and how effective at that time did you feel your treatment was, and what you needed to do to kind of make you fit in with everybody else? And
well, back then as a kid, there was a taboo / stigma with kids, as you know. So I was kind of hid it because they thought it was comparable to cancer, HIV, and things of that nature. So there was that taboo and stigma with kids. Also, there's going to the hospital. When you go to hospitals, they think you're coming in for a fix, for morphine or Demerol. So there was always that, some nurses and some doctors who are not as cumbersome with it, or they don't know much about it. Well, your vital signs are fine, your HB is 10, 11, 12, you look good, you don't look like you're in pain. I'm not yelling, I'm not cussing them out. So all of a sudden, they don't know that I'm in pain. So you try to explain that to them. But I believe there was a program whereby NIH was involved with gives sickle cell patients an ID like this, whereby it tells them, this patient has sickle cell, and they're able to see all their records and the vital signs of the doctor and so on and so forth. So I believe in every hospital see their record, sort of from that stigmatism.
How has your sickle cell disease affected your relationship? I know you are a father of 2, happily married, and still active with your teenage girls. And so could you let us know how you've been able to manage that aspect of your life?
Well, family is key. My parents, my siblings, my wife, and my kids. I mean, I have a very supportive family when it comes to sickle cell. Yeah, there's some activities that I'm not able to do, or shall I say, I caution myself. I don't drink, I don't smoke. I try not to do anything too strenuous. I play table tennis. I love playing that, and sometimes I play table tennis all the way to start having pain. So basically, once your limitations, sometimes I can't, go out play with my kids, and, they play basketball in AAU, up and down. We have a basketball court here in the rim. So I try to sort of, walk the fine line without doing too much and, getting myself in the hospital. But I'm able to manage it. Once you're able to manage it, know what to do. I stay hydrated, take my meds, folic acid. I'm fine, I'm stable. So, family is key. They help me out a lot. Sometimes I'm not able to walk. I remember there was a particular situation where my dad had to carry me on his back many years ago to the hospital. So I was in excruciating pain back then. So yeah, family is very key. So I have a few friends and close friends that also support me. They're like family, and they know about it. So once you have those around you, a good support system.
What medications are you on now, and what other things are you using to keep you as healthy as you are? Looking at you, you don't fit the stigmata of sickle cell patients.
Well, currently I'm on folic acid, of course, Tylenol with codeine, OxyContin. I've tried, there are other, therapeutics, different, herbal supplements. Hydroxyurea, my doctors at, you, Dr. Onyekwere, and Dr. O'Neill, and so on, they've all tried to, get me on hydroxyurea for years. Now, something kept telling me I shouldn't use it, and I should have followed my instincts. Now, this year I tried it, and then I reacted to it. I had a rash all over my mouth and face, literally. So I stopped it. But in the past, I've used Niprisan, which was part of a group from Nigeria. It was an Abuja, Nigeria Institute of Pharmaceutical Research. There was also Auricula, which you know about. You met Mr. Agbo. He, my uncle, may so rest in peace. He developed that. It's all herb-based. And of course, there have been numerous herbal supplements like that. I've also used, acupuncture, which I know you're going to talk about later. So yes, those are things I'm on now. I'm looking at Oxybrita and Dari, which, they're all expensive. Insurance companies refuse to cover it. And they cost about $10,000 a month. So, I'm not on the government insurance. I'm paying out of pocket. I'm paying them for years. And all of a sudden, when it comes to then, living up to their bargain, they tell me, oh, sorry, we can't cover it. So there's also that stigma. So that's what I'm using right now.
So the last thing I would like you to tell us is that looking at your whole management, looking at where you are now, looking back and looking into the future, what would you want us as your providers to do in terms of giving the best of us to sickle cell patients?
Okay. Well, I believe that currently we need a lot more research, a lot more funding, a lot more awareness. Basically, it shouldn't just be, autism, cancer research, and things of that nature, or quote unquote, not to get on the racial lines, but yes, it is a predominantly Black disease. So I believe that awareness, that bureaucracy, if we can sort of hash that line out and get more funding, because I don't believe that in 2021 we can't have a cure for sickle cell. Yes, I know you argue that there is a cure, stem cell research, or stem cell transplant, which is not a cure for everybody, because I took my sisters to NIH, they drew their blood, and they said they're not a match. So if they're not a match, that cure doesn't work for me. It doesn't work for everyone. So a cure is something that works for everyone, that's applicable to everyone, financially, costly, physically speaking. So awareness, research, funding.
Thank you very much. So I'll go right on and ask Dr. Onyekwere to be our next speaker. Dr. Onyekwere and I have worked together with sickle cell patients at Howard University Hospital, and currently now she's the chair at the Holy Cross Hospital, Germantown, Department of Pediatrics. She's also the medical director of Neighborhood Pediatric LLC. She specializes in benign hematology and general pediatrics, and she has dedicated her career to the care of sickle cell patients. So over to you, Dr. Onyekwere.
Good morning, good afternoon, and welcome to this year's Sickle Cell World Day, and also Juneteenth. Okay, disclosures on nothing except that I'm in the Global Blood Therapeutics Speaker Program. So I talk for them regarding Oxybrita. And today's outline just go over, most is under pediatrics, but pediatrics also is where you start with sickle cell patients. We'll do an overview, newborn screening, management, and that maybe long-term outcomes. We already heard from Mr. Ore about how he's doing with his sickle cell. As we know, sickle cell disease affects mostly people of color from Africa and Middle East most of the time. As you can you see my arrow? Thalassemia is the yellow section, sickle cell is green, so it's spotted in the Middle East and in India. And sickle SC is mostly under the Western Coast, Ivory Coast, Senegal, and the area. In the US, this is the distribution of sickle cell in the US. Usually Florida and New York has the most concentration, followed by Maryland and Texas and California. We know about genetics of sickle cell. Everybody here is aware of sickle cell. It's a recessive gene. One is inherited from parents. So both parents are carriers. There's 25% of the child of each pregnancy that they have a patient with, they have a child with sickle cell disease. And the pathophysiology, we know that is a disorder of the beta globin gene, sickle cell hemoglobin S versus any other hemoglobin mutation, whether it's C, E, D, dependent, will affect red blood cells solubility. And also it could be associated with alpha thalassemia, which actually ameliorates the disease a little bit, as opposed to having heterozygosity with any beta globin gene mutation. The polymers that are formed during deoxygenation in sickled red cells actually causes hemolysis and vaso-occlusive disorder, which is the hallmark of sickle cell disease. As we can see in this cartoon, usually you have anemia associated with vaso-occlusion and then hemolysis, which could be either way. So hemolysis could be caused by, could cause anemia, or vaso-occlusion could cause anemia by hemolysis. And of course, all these have cascade effects on their tissue. Wherever you see hemoglobin disorder, whenever you see blood, when the patients have asked me, which organs are affected? I said, wherever you have blood going, the sickle cells, they affects your organ. You might not feel it, but it's there. And hemoglobin, as we know of it, develops in utero. And people say, why babies don't get it till about 6 months, you start seeing signs of sickle cell manifestation. As we know it, fetal hemoglobin is alpha and gamma, and it starts from in utero and stabilizes and drops then after birth to about 48 weeks. However, pardon? Okay. However, depending on the type of sickle cell disease that you have, or heterozygosity, compound heterozygosity that you have, the gamma globin might persist and the fetal hemoglobin might persist. And this is also what most pharmaceutical companies are now working on in terms of developing drugs or gene therapy to see how can ameliorate this. We also know that sickle cell disease is the first genetic disease discovered. Now we're what? The 21st century, and we still don't have a cure other than transplant. So most of the slides you're going to see might be old slides, but they're still the same. Nothing has changed other than the new drugs. The hemoglobin disorders, there's quantitative, which is in thalassemia or decreased production, and qualitative, where sickle cell disease falls under. The hemoglobinopathies, the sickling disorders and non-sickling disorders. And of course, we have the hemoglobin S and hemoglobin C, which is decreased solubility. Hemoglobin cancers is decreased oxygen affinity. Cyclus is mostly hemoglobin F, so you have affinity to oxygen. In terms of diagnosing sickle cell disease, initially we started with isoelectric focusing on electrophoresis, but now the gold standard is HPLC. Why do I mention this? Because when you do, especially back home, which I have found when talking to some patients, when they do hemoglobin electrophoresis, they're only focusing on the S. They're the isoelectric focus. They're not focusing on any other elutant. Therefore, if they have sickle beta thal, they say, oh, you're fine, you have the trait. And then they have a child and the child has sickle cell, and the question is, how did somebody's lied to me? So it's very, very important that hemoglobin HPLC is done now. And we're advising most pediatricians, especially for immigrants that just got here, don't know their genotype. In my practice, the goal is to get hemoglobin electrophoresis on anybody that walks through that door that's never had it before, so that we're determining whether they're sickle cell trait or they have any other hemoglobinopathy. Mass spectrometry and DNA sequencing is done depending, these are not available in Nigeria. And then Dr. Onojobi wanted me to talk about athletes. The CDC, this site has good recommendation for individuals with sickle cell trait that are involved in sports, and that they should be their guidelines, and they should not be discriminated against as long as they do what they need to do. Keep hydration, make sure they're not on low oxygen tension areas, so that they will be or train slowly so that their body can adjust. In America, and also started in Nigeria now, there is a newborn screening program, mostly in Ahmadu Bello and in Abuja. Here in the US, every child in all the states now do get hemoglobinopathy screening is available, and that is reportable. So, excuse me. This slide, as you can see here that I'm depleting, FAS, okay, means that the person has, usually when they report your hemoglobin, hemoglobin F, they go by the percentage. So percent F is higher. Of course, you expect that in a newborn, and A followed by A, and S is smaller. So this is a patient with sickle cell trait. FAS is not the same thing as A, FSA. When you have FSA, that means you have S is higher than A. So FSA is different from FAS based on the percentage. So a patient, you see a newborn screening result comes back to you, or the patient comes to you and say, this is what I have, FSA. That means that patient had percent S is higher than A, so he probably have beta thal, sickle beta thal plus, not 0. FA, so the same thing with this. So FA is normal. FA is sickle cell trait. FS is, of course, is sickle cell or HS or beta thal 0, which are the severities just about the same. FSA is beta thal plus, and FSC is hemoglobin SC disease. Of course, we talked about the hallmarks, vaso-occlusive crisis, and hemolysis. Sickle cell, as I was stating before, sickle cell clinical manifestation affects everywhere the blood goes. The brain, so you have stroke, or you can have silent strokes, and they have decrease in school function. That's how you know that probably something is going on. So a child that is doing very well all of a sudden has issues with school or behavior, then you have to look forward, or hearing loss. And this is a sickle retinopathy, does happen. They do have crisis. And of course, you send them to the ophthalmologist. So this is a cartoon of sickle retinopathy. This is neovascularization in the orbit. It affects the liver, so most of the time they're jaundiced and cholelithiasis can form. There's growth and endocrine dysfunction. The puberty, they have the sickle cell patients have delayed puberty. So a young girl might come to you and they're 16 years old, they haven't started their menstrual period. So you have to think twice before you are say, oh, this is, there's something going on. Get a good history, send them to do a hemoglobin electrophoresis, and then of course, send them to the endocrinologist. The hand-foot syndrome, dactylitis, you see that at, usually that's most of the time is the first presentation. Some people at times with some healthcare providers, some would think that is osteomyelitis and are sent to rheumatology. But if this is a young girl new to you, or you see that patient in the ER, the mother brings that baby, always African American or Hispanic, always think about dactylitis. And hydration and ibuprofen helps. Priapism in the young ones, and physical disability, they can have joint pains, osteoarthritis, reduced fertility, delayed puberty. We talked about splenomegaly or splenic sequestration can occur. In the chest, you have acute chest syndrome, and there are, of course, hematuria, neurosis, and papillary necrosis and sequestration can occur also in the kidneys. And you just have to work with these individuals with each one, and I always educate each time they present to your clinic. Okay, so this is dactylitis, and this is cholelithiasis. Of course, you know about the jaundice, and this is a stroke. Normal spleen, sickle spleen. So that's why they placed on that. Sorry, I'll talk about that later on. Management of sickle cell patients. Of course, we do universal screening. Thank God we started that in Nigeria now, and hopefully gradually will spread to other states other than Ahmadu Bello University and Abuja. Family education is very, very important. When patients present, the first thing you tell them is, this is going to be, guys going to be married together for the rest of the child or the adult life. Close contact with your primary care providers or your hematologist is very, very important, because there are always new stuff going on, and educate the patient, and patient educate yourselves. Penicillin prophylaxis is started from 2 weeks of age. So now the OBGYNs, when is mandated that in the US, that they screen any African-American couple for sickle cell trait or disease. So if both partners are positive, then they have to educate the parents. And when the child is born, then of course they get the newborn screening. And once the state gets the result, they send it to, usually the state would have we'll call the primary care doctor, and also send it to the children's hospital, the closest children's hospital. And the primary care doctor will contact the parent, they'll contact the primary care doctor, and they send information to whoever. If it's in DC, DC Health has their own nurse coordinators that go out to the homes and talk to the family, and also their primary care doctor. Where in Maryland, they contact the primary care doctor and of course send to children's. And then there, within 2 weeks, it started the penicillin prophylaxis. And that has shown to reduce mortality in these patients. And immunization, all the childhood immunization started. Hepatitis B started at birth. And at 2 months of age, from 6 weeks and up, they start a series of other immunizations, including pneumococcal and diphtheria. Transcranial Doppler starts around age 2 years of age to screen for stroke, and it's shown to be very, very reliable and reduce morbidity. Because once identify abnormal transcranial Doppler, the patient is started on transfusion protocol. Of course, there are side effects from transfusion because chronic transfusion will lead to iron overload and the patient goes on and desterol or hydroxyurea combined. Also, now there are a few drugs that are available for sickle cell disease. Hydroxyurea comes in different forms. A typical one is 500 milligrams. They have it in 200 milligrams, now 1,000 milligrams with 6 dose, and Hydroxyurea is 400 and 200. Of course, we have the oxybrita that you can take with hydroxyurea, and that has also shown to improve the hemoglobin lifespan. And Adecovir is also good, but that one is IV infusion by Novartis, and you have to go to the hematology clinic and get that every month. And Dara is the L-glutamine oral powder that you mix in water and drink every day. Of course, we have the stem cell transplant or gene therapy. Fever, sepsis is managed, is a medical emergency in sickle cell disease, temperature 100.4 and above. The patient, the pediatrician should have a plan with the family in that if have an extra doses of penicillin available, especially if they're not close to a hospital or urgent care, so they can administer that and then take the patient to the hospital or the ER. They do have now, every sickle cell patient should get flu shot every year. Now we have COVID, and it's recommended that they get COVID every, probably we're gonna start getting it every year with all the variants that are being shown. So I hope that everybody has had their COVID vaccines. We talked about the management, the stroke or silent infarct. So we get an MRI and MRA if there's abnormal TCD, and don't wait to schedule the MRI and MRA. Start transfusion, because at times we take, depending on how backed up the radiology is. We have situations where in pediatrics, you said, okay, let's get the MRI and they start transfusion, and the patient had a second stroke. So you don't want that.
Okay.
You want to, any abnormal TCD will be, we'll start transfusion right away. So this is just, thank you. Mm-hmm.
So we'll take the questions after that, and then I'll ask Professor Akinola to give us the adult perspective of this, and then we will talk about the other non-pharmacological management of sickle cell. Hold on, please. So Professor Akinola, it's Professor of Hematology and Oncology from Obafemi Awolowo University. She's joining us in bringing the perspective of African as well as the Western as well as Nigerian perspective to treatment of sickle cell disease. She has spent a lot of her career in sickle cell and HIV, and she's well published. So we welcome Professor Akinola to the forum. Thank you.
Thank you very much for inviting me to join this forum today. May I congratulate everybody for this opportunity to interact on the way forward for our patients with sickle cell disease. I've been asked to talk about the management of adults with sickle cell and the challenges and the way forward in Nigeria. I want to thank Dr. Onyinye Onyekwere for giving a very detailed pathophysiology of sickle cell, so it's made my work very easy. So I'll be using this outline. So adolescents and adults. So usually adolescents are young people who are 10 years and 24 years of age. And in Nigeria, transitioning from pediatric to adult care occurs on average between the ages of 16 and 18, or as soon as a child is too large for the pediatric burden. So that can be as early as 12 years. Very few hospitals, however, have established transition clinics for patients in Nigeria. So a successful transition from pediatric to adult care has been shown to correlate with better outcome in patients with sickle cell disease, and due to better adherence, medication management, and self-care. So the transition of care from pediatric to adult involves basically an acronym, SICKLE, where S stands for skills training to empower young people. I stands for increasing self-efficacy through a person-centered approach. C standing for coordinating transition through community health workers or navigators within the hospital. And K, knowledge transfer through health promotion. L, linking to adult services to ensure continuity of care. And E, evaluating readiness for transfer of care. We found out that many of our pediatric patients are so dependent on their parents or caregiver that they find it very difficult to transition between the pediatric clinic and the adult clinic. And even when they are referred and they do come for the first time, they disappear for a while before they come back again, probably when they have crisis and they have nowhere else to go. So it's important that we try and look at this critically. So the baseline has been set for me, so it makes my job quite easy. So sickle cell disease has been described. We know the root cause, the mutation of the beta globin gene that has given rise to hemoglobin S, and that is what has caused all the problems that we're dealing with in sickle cell disease. So remove the mutation and replace it with a normal hemoglobin gene, and then the problem is sorted. That is the cure of the root cause, is by hematopoietic stem cell transplantation. So this is either done by full match with the sibling donor or haplo-identical half match with a relative. We'll talk about the challenges later. This is just a summary of what I will talk about in challenges. So if we can't get the cure, we know that this is very expensive and it's not readily available to many people. So we go back to controlling and preventive measures. So as part of the controls, we're talking about preventing marriages between a sickle cell trait, hemoglobin AS individuals. Now this is a tall order, this is difficult. Very recently, a medical student came to me knowing that he's a carrier and his girlfriend is a carrier. Came to me to have a look at his blood samples again and to try and find out a reason why he should still marry his girl. So unfortunately, it wasn't to be. So, but even with the knowledge, people still try to find a way of marrying their loved ones rather than looking for tray getting in the way. So if at the end of the day you find trays getting married, because sometimes you can't just prevent them from marrying. So we introduced prenatal diagnosis, and this allows them to test the unborn child very early in utero, around 10 weeks of gestation, to determine the hemoglobin type of the baby before it is born. So they are informed as to what the baby is likely to have, and they make definite plans to deliver the baby and look after the baby, or they have the option of terminating the pregnancy if it is permitted in the environment. When the baby is then born, then do newborn screening. Now, newborn screening has been mentioned earlier. In Nigeria, it's in its infantile stage. The federal government set up 6 machines in 6 geopolitical zones of Nigeria some years ago. However, the machines were not well maintained and the outcomes were quite miserable. But there's an effort now to start newborn screening, and have in the north and then in Abuja recently. And we hope that other centers in Nigeria will catch on to this and help to improve screening of newborn babies. Because if you catch them young, it is you use what we call comprehensive care model to prevent disease. So this preventive measure starts right from birth. Even though we know that hemoglobin F doesn't go down completely, and hemoglobin A, the S in this case, does not reach full adult levels until about 6 months of age. So once a child is born and it's known to have sickle cell disease, that is the time to start preventive measures. And the preventive measures have been clearly stated by Dr. Onyekwere. Again, the use of transfusion, chronic transfusion program is also a preventive way of reducing the frequency of crises in patients who have very severe disease. However, if control fails, then we need to look at the downstream effects of sickle cell disease. And that is the various complications, acute and chronic pain, management of complications, end organ damage, and prevention of infection. In Nigeria and African countries, malaria is a major cause of vaso-occlusion and painful crisis. So it's one of the things we try to add to the routine medications. The disease modifiers, hydroxyurea, a lot has been said about it, but it's still in the uptake of hydroxyurea in Nigeria is still rather low. And it's because people are afraid of the side effects or complications, particularly the infertility aspect of it. And we're trying to help them understand that this may not always be so. We've had experiences of patients who use hydroxyurea for other diseases like CML, chronic myeloid leukemia, for example. And we see some of our patients having babies while they're still on therapy. So it may not always be so. However, things do change from patient to patient, and not every patient will behave in the same way. Some people will tolerate hydroxyurea and some will not. And for those who can't tolerate it, that is when we now look for other options. So the newer drugs, the L-agglutinin and all that has been mentioned before by the previous speaker, are not readily available in Nigeria right now. And in fact, they're still under clinical trials, and it's difficult to get onto clinical trials at this time, even though we're trying to find our way in. So we tend to depend, patients, not we the doctors, is the patients that look for respite in herbal remedies. And there are so many in the market. Our patient advocate has already mentioned some. Niprisan, Ciclavit, and it's a good it's a good number of them that are available that our patients claim work for them. So, but we don't have clinical trials even on these herbal remedies, and we need that. So, what are the challenges? Challenges with control and especially with control is stigmatization. People feel stigmatized when they say, is an AS, can't marry AS, and AS wasn't married. Yes, and even when they are diagnosed to have sickle cell disease, they feel stigmatized. People don't want to come up to say, yes, I have sickle cell disease. Very few of them do come up and give us testimonies of their experiences, just like our patient advocate has done earlier. So, but stigmatization is the act of treating someone or something unfairly by publicly disapproving them. That is the Oxford Dictionary definition of stigmatization. So you find that a lot of our patients actually self-stigmatize themselves, all right? So you find that the ones, even if the community are not actually disapproving of them publicly, they are hiding and they don't want people to know how sickle cell disease. So the challenges we have with chronic transfusion program, and that is not common here because of immunization problems, iron overload, which are difficult to take care of when it does set in because of non-availability of drugs or they're too expensive. And then bottom line, inadequate supply of blood. Yes, we just celebrated World Donor Day last Monday. That's how many units did we get in our hospital? Very small. So people still are not, cooperating with the service to give voluntary donated blood. When we look at the challenges associated with the management of the downstream effects, we find that, as I said, with that hydroxyurea, the infertility issue, we're trying to overcome that. And then it's expensive for some, it's not too readily available. Some people still say it's not cheap enough. Yes, we have locally made hydroxyurea. We have a pharmaceutical company that produces hydroxyurea for our patients at lower cost. But even then, that is not cheap enough for all. What about insurance? No insurance. Well, technically, yes, we have, but it does not favor the patient, individual with sickle cell disease as at now. We are hoping that in the near future, things will change. Today, we have limited access to clinical trials. Now, in the management of pain, we really do have challenges. And that is in the availability of morphine and morphine-like narcotics that will be effective. We don't have slow-releasing morphine, slow-release medications. And the morphine we have is not even parenteral, it's syrup morphine. And some patients react to this and they can't take it. So they have to give them drugs like pentacid. Again, we are not spoiled choice, so we're limited in the choice of analgesia that we use. So we then find that pentacid has a high dependence rate among our patients. And that is another challenge, a major challenge we hope to be able to overcome when stringent measures are put in place to prevent patients from buying this. Immunization, again, is expensive. Many patients can't. So, however, we found in the course of our research that adherence to routine medications are not a constraint for patient care. This, in order to get good outcomes, improve quality of life. We found that our patients really don't adhere to taking their routine medication, folic acid, complexes, and even the anti-malarials, they don't take regularly. So where do we go from there? Now, the transplant, addressing the root cause, is so expensive, mortality rates, issues. And in Nigeria, there's only one center that is in Benin that is currently transplanting patients with sickle cell. And we hope that the Sickle Cell Foundation, in collaboration with Luce Hospital, will start their own transplant next month, hopefully, in collaboration with Nashville, Tennessee doctors. So we find that getting a compatible sibling donor is another challenge in this area. It's the best way to go for transplanting sickle cell patients using reduced intensity conditioning. But you find that within a family of maybe 2 or 3 children, there's a chance of 1 in 4 getting a sibling that will be fully compatible with the patient. And that is a total death. So and nobody does haploidentical transplants in Nigeria as of just a little mention of pain, because pain is the it for sickle cell. Without the pain, we probably wouldn't have so much problem. That's my opinion. So the definition of pain by the International Association for Pain, the study of pain, says that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. In medical diagnosis, pain is regarded as a symptom of an underlying condition. Another definition, I have two other definitions here. The last two, you're saying acute pain is pain that starts suddenly, usually as a result of tissue injury and lasts for less than 6 months. It disappears as soon as healing takes place. That's acute pain. But if it doesn't, we're talking about chronic pain, which occurs, after acute pain has been ongoing for more than 6 months, and it can even continue to linger even after healing. But one of my patients had described sickle pain as like this. It is worse than toothache, worse than fracture, worse than labor pains and migraine. It's like Brillo pads being pulled through your veins at the same time. In this insert is what Brillo pads look like. Is an iron mesh, covered up with soap. So it's iron fiber wool that is pulling. So you can imagine the extent of that pain. Pain is the hallmark of sickle cell disease. It's usually due to vaso-occlusion. And vaso-occlusion results in tissue damage that causes the release of biochemical, neurological, and electrochemical substances, which result in the perception of acute pain. This is the perception. Now, it has been reported, I think I like this, that the psychological, social, cultural, and spiritual factors often unite and conspire with vaso-occlusion to initiate the unique nature of sickle cell. That is Ballast 2007. So we have been studying pain in sickle cell into a lot of detail, the level of rheology, and Ballast and Spin in 1992 and Auricula et al. At the same time. We were able to report for the first time that painful crisis evolves in long phases. And it was later that Bayer and Jacob did similar things and confirmed the same using different names in Chile. And these are examples of the schematic representation of what we have observed. That is, there's the prodromal phase, which means patients know when they're about to have. So is it possible to abort crisis even at that stage? Then by the time you have initial phase, and it's too late to abort there. So this now metamorphosis, progresses into the established phase, and then with the resolution of the crisis of the vaso-occlusion, you have this resolving phase. And these are the schematic representation of the changes that you find in the stem cells, plug-in particles, and the acute phase reactants. So the steady state, because sickle cell is basically divided into steady state and crisis.
Wow.
Crisis has been fully discussed earlier, but the steady state, broadly speaking, is when there is no pain or any change in the blood due to therapy. Now, the steady state may also be defined as a period free of crisis, free of pain, extending from at least 3 weeks from the last clinical event and 3 months or more since the last blood transfusion or intervention, to at least 1 week before the start of a new clinical event. Now, the duration of the steady state varies within an individual from time to time and in between patients. And vaso-occlusion may also be responsible for the state of chronic vascular inflammation. that explains many features and complications of sickle cell disease. And treatment of painful crisis. Obviously, we've been talking about morphine and all that. Blood transfusion, top-up and exchange, challenges with that. And then management of the specific complications like stroke, acute chest syndrome, and priapism. There's no size fits all the management of pain. This is the original and the revised WHO analgesic ladder. And so what's the way forward for Nigeria? Prevention is always better and cheaper than cure. The Nigerian Parliament is in the process of passing a bill right now to support control and care of patients living with sickle cell disease. It should include the routine medications, immunization, hydroxyurea, and chronic transfusion program under the NHIS, which is the insurance scheme that we have here in Nigeria.
Was there a problem before?
We hope that there will be an increased support of newborn screening, and then we need to facilitate the establishment of pediatric to adult transition clinics. Stigmatization is a major hurdle for us in Nigeria, and there's a need to establish more support groups and clubs. In Nigeria, CHOOS, that is the community health extension workers, or low and middle level healthcare workers, to be trained and retrained to aid transition from pediatric to adult care. And we found that the CHOOS are in the best position to reduce loss to follow-up, which is what we find, especially after results of newborn screening have been obtained. Screening of hemoglobinopathies should be made mandatory at all levels of education.
Thank you so much for Professor Akinola for your
Thank you very much.
depth presentation. In moving forward, I am going to present other treatment that as we have alluded to, that sickle cell patients treat themselves at home, and to encourage them and look at other non-pharmacological treatment that may be available to them, especially things that are easily, that they can just do by themselves. On that note, I'm going to share my slide with you. I am Dr. Onojobi. I am hematology oncology. I did a lot of sickle cell management at Howard when I was there, and we had this study on research and trying to decrease stigmatization of sickle cell patients. Non-pharmacological treatment of pains in sickle cell, in patients with sickle cell disease. What a lot of us as caregivers don't understand is the breakdown of pain in sickle cell. Epidemiology study that was done by what is called PIECES found out that most sickle cell patients treat their pains at home. Very few, less than about 4% of the time that they have their crisis, do they come to the hospital. So like Professor Akinola has said, a lot of patients are lost to follow up. So if we can incorporate how they can manage themselves appropriately at home, that would be another step forward. So we have what is now called interdisciplinary approach, where we have combination of intervention modalities, both pharmacological and non-pharmacological. We've heard a lot about the pharmacological aspect of it, and I'm going to try and talk about the non-pharmacological therapy. A lot of sickle cell patients will tell you they use heat, they get into the shower, hot bath, they use a lot of massage, relaxation techniques. They try to concentrate on their work, hypnosis, meditation, and distractions, and including acupuncture. We know the limitations of all the current medications we have. We've had a lot about that, including blood transfusion. And you have to realize that African Americans and Africans are the least people to volunteer their blood. And that's why a lot of Black people get Caucasian blood and they develop allo antibodies. So if we can encouragement of blood transfusion, should be blood drive, it's key to minimize the complications of blood transfusion in sickle cell patients. So NIH, to this effect, NIH has been looking at acupuncture, and they did a retrospective study, Lu et al., whereby they had 47 patients that were just allowed to, inpatient and outpatient, to use the acupuncture. And at the end of it, they found out that for both chronic and acute pains, 75% of patients in the outpatient described that they had improvement. And in the inpatient, there was considerable improvement in their pain. NIH has actually given University of Illinois, Chicago, $7.1 million for the next 5 years to look into effectiveness of acupuncture and guide relaxation of people with chronic pain. So as providers, we should make these options available for the patient so that it becomes something that is available to them. So in essence, what is acupuncture? NIH says that acupuncture is a process whereby you have insertion of needles into predetermined acupuncture points to improve disease process. Acupuncture is an Eastern medicine. All over the Asian region, continents, including Japan, they have used it for centuries and it has worked for them. So now it's been introduced into the Western medicine, and it's been acknowledged that it can take care of both acute and chronic pain. It's used a lot in cancer management for nausea, vomiting, anxiety. It's also used for addiction, for treating addiction alone or with other modalities. And in West Virginia right now, it's being taught to frontline responders, ambulance driver, ambulance crew, patients in the clinics. They get certification to help the patients who present with opioid addiction or opioid overload. It works. What's the theory behind acupuncture? The theory behind acupuncture is the concept of flow of energy through different spots, which are called meridians. And these are pathways which are said to be connected to the body from the head down to the toes. And therefore, if there's a disruption in that flow, then it causes disease. And the disease can manifest itself in different aspects of the body. Not necessarily when you have nausea, it has to come from GI. Nausea can come from pain, like if you stump your toes or something. So if you apply the needle to this meridian points, it will activate those points and restore the flow of chi, as it's called, and restore health. In Western medicine, we have tried to say acupuncture may mediate various pathways in the CNS. And there's something called Auricula Acupuncture, where when you look at the inner ear, external ear of everybody, it resembles a fetus in the womb. And therefore, it's associated that every organ in the body goes to this meridian and is connected to the brain. That is why the ear itself on its own can be used in the Eastern medicine to treat any part of the disease. In fact, some people have said that they can even use it for surgery, some surgery, but it has not been done in this area, but that's what they do. So these are the meridians. There are more than 2,000 meridians in the body, both front and back. And so you have to try and connect the dots. Say patients with sickle cell, as we said, sickle cell patients have different symptoms when they are presenting. They have pain, some have pain, some don't. Some have fever, chills, and all that. And this is because it is assumed that they have a dysfunction along their meridians. And therefore, the treatment should be individualized. It's not the general symptom that you give to everybody else. In addition to what we do in the Western medicine, this is something that is being looked at. So if you look at this slide, these are the various acupuncture points that have been established that can be used for sickle cell patients and patients who have pain because of this polymorphism in the presentation of patients. So some can have underlying anxiety. The way you treat them will be different from someone who went on the sports and had pain all over. So everything is put together, and then you decide which points you would use for this patient. The other thing about acupuncture is that it's not something, it's holistic. It's not something that can give you, it can give you an immediate effect, but you need to work on it constantly. It's like a maintenance of health. And a lot of people give up after a while because they get better, and then it's a maintenance thing so that you can keep your chi flowing. Sickle cell already has an underlying disease that is functional to them. And so they will benefit a lot from just going for acupuncture on a regular basis. What is the benefit of acupuncture? It decreases the pain, it decreases the anxiety level, decreases the amount of time patients have to go in and out of hospital. It can be done outside as a business. It can be done by people who are trained to do that. And it's also can be used to help patients who are already dependent on pain medication. And this might be an option for areas that don't have a lot of pain medication that is available to them. So what are the limitations of acupuncture? It does not conform to the Western medicine ideological concept of organ structure etiology. The skin is almost as important as the liver, as the spleen, and as the ankle and everything else like that. So it's more holistic, involves lifestyle changes, and therefore results are not immediate, but prolonged. So just to show you an example of how this is called the Simplified protocol treatment for opioid addiction. It's done by the National Acupuncture Detoxification Association. It's called NADA. If you look at the ear, you will see that that is a fetus in the ear. And so these specific points are called sheme, kidney, lung, liver, and the sympathetic chain. So if you needle all these points, the needles are very, very fine. If you needle all these points on a regular basis, say 2 to 3 times a week, for a period of 6 weeks, and you're talking to the patient, and you already know their underlying disease, which you're also going to address, many people after 6 weeks are off opioids. And that's why West Virginia is really certifying a lot of people to do that. So these are my references. I don't have much to say anymore, but to say that we should look at other forms of modalities that can augment the treatment, not only of sickle cell disease, but also of all other diseases. Thank you very much. Going on to our next speaker, that is Dr. David Ajibade. He comes to us. He is the director of Brain and Body Solution LLC. He also is from Abuja, based really in Abuja, but he travels a lot, and he has going to talk to us about the concept of using immune boosters to treat sickle cell patients, because not all sickle cell patients have access, as we said, to any of these treatments. Most of them only have folic acid. So they're looking into the concept of, we know that there's decreased immunity in sickle cell patients because of the autosplenectomy. We also know that they have, from wherever area they might be nutritionally deficient, they might need things like vitamin D. We don't look at those aspects of it at all. We just treat them. But there are other things that we can use to boost them up so that they become more resistant to the crisis. So on that basis, I will invite Dr. Ajibade to give us his presentation.
All right, thank you very much, Dr. Norah Olubunmi, and a big thank you to ANPA for this opportunity to share this, to talk about some of the work we're doing, and of course, the research that we're hoping to do in a few, not too long from here. I will go ahead and share my slides. Good day, everyone. Okay, can you see my slides now?
Yeah, we can.
Okay. So as Dr. Onojobi said, actually is we do have a brain and body solutions, but I'm coming to you under the auspices of the foundation because that's where we do our research under. And yes, we're going to talk about the research that we're doing in the next 10 minutes, but also say a few things about how we came about doing what we're doing. Our end result really is that we are hoping, in fact, desperately desiring that the federal government consider the inclusion of immune system supplements in routine medications. Right now, as Dr. Onojobi said, it's just folic acid and antimalarial. So we are hoping that with the research that we're going to do, we'll be able to provide the data for that move. Just a little bit about ourselves. We are based in Abuja. I'm currently in the US, but trying to, in pursuit of what we're doing with the research. We've been approved by the government to do several things. We've been address brain disorders, mainly medically fragile children, brain disorders, chronic conditions, and of course, sickle cell disease. And we use specifically nutraceuticals. I am a medical doctor by training, but in these conditions, we found out that the safest way to go was to go using nutraceuticals or nutrients. Where some papers are coming out soon. We've already published in the paper on brain disorders. And we do a lot with charity-wise every Friday. And people from around the city can come over, especially the poor. And I just want to say something about that. The poor don't have access to all the things that we've just heard. They don't have access to acupuncture or MRI scans, CT scans, even blood transfusions is a big problem. And from what I've heard, over 50% of the population lives in remote areas and villages. So many of them will not have access to these things. So we're always thinking in terms of the lowest common denominator, if you will. The lowest common denominator, what can we do for the person that is in the village, the Asikira, for instance, who sells granules or yam? What can we do for her if a child has sickle cell disease? What can she do? What can we do that will help the child? Now, we're not treating crises or anything like that. We are there to support the body so that they don't have or fall into that problem of having a crisis and having to look for a hospital. And quite frankly, many of them don't even know if they're going to die, or they tried some herbal remedies, which many times don't work. So I'm going to talk about this last part, the approval from the Ministry of Health. The reason why we came into sickle cell disease, we started with brain disorders, like I said, but we were pretty much blindsided and drop kicked into the whole world of sickle cell disease. Why? Because we started having kids coming to treat the brain disorders, which were strokes. Many these kids before the age of 10 were having multiple strokes, and they're being wheeled in on wheelchairs by their parents. Only to find out that over 10% of kids with sickle cell, 10% of individuals with sickle cell disease will have a stroke in their lifetime. And the peak time is between the ages of 2 and 16 years. Kids with sickle cell disease are 200 times greater risk of having a stroke than the average person. You've already seen a slide like this, so I'm just going to skip through. I've been told I have only 10 minutes, so I'm going to rush. I'm going to rush through this. The problem with screening and the problem with preventing marriage and all that is definitely a step in the right direction. But we have a bench strength of over 40 people. And so it's hard to, and since many of them live in the villages and they don't have access to tests, it's hard to really police that. This number here that I'm looking at, over 100,000 will die annually from sickle cell disease, most of them before the age of 5. So that is the big problem. So back to our concept. Our theory is that if you improve immune function in a child with sickle cell disease, and I believe we should start as early as possible within the age of 5 months, using nutrients is a good way to go. A few things about the sickle cell disease. Why focus on the immune system? There are 3 reasons why we're focusing on the immune system. One is the top cause of death. Infections, the top cause of death. 2 is one of the top causes of crisis. And 3, it's important for your overall health. If your immune system is working well, your overall health is working well. This is especially important in sickle cell disease. So like I said, it's the number 1 top cause of infections is the top cause of death is infection. If your immune system is weak, you're more likely to have a crisis. It's also the top cause or top trigger for a crisis. And of course, malaria, typhoid, are very, very common in Nigeria. I just want to say a few things about why immune function is poor in sickle cell disease. Obviously, Dr. Onojobi mentioned it was splenic function. Sometimes of these kids have outright autosplenectomy, so the spleens are totally absent. And as we know, the spleen is a very potent immune organ. It's very important in the immune system. But in addition to that, there are problems with complement pathways. There are problems with the neutrophils, and there are even instances where they're showing that macrophages too have problems as well. So the immune system in individuals with sickle cell disease is deficient. And some of the infections that they are more prone to, especially they talk about the spore-forming organisms. The two in red here, I've listed many of these are the top infections that they see in sickle cell disease. The two in red here are some of the most common, and in the US and in the UK, I'm sure in other countries as well, they're already giving them prophylactic antibiotics and prophylactic vaccines to prevent them from having these infections. Unfortunately, the question is, what are we giving in Nigeria? Now, I don't know if it's being done in the major hospitals, Luth or ABU. I don't think it's being done in Abuja, in the hospitals in Abuja. But the main things that we're seeing in general hospitals, you ask any pediatrician, the main supplements that they are being given are folic acid and antimalarials. That's it. They're not giving hydroxyurea, they're not giving multivitamins, they're not addressing any of the other new remedies. Of course, they're not giving oxybitra, which is $10,000 a month, which is $10,000 more than what the average person can afford. So they're only left with folic acid and antimalarials. And I have to say this, I'm a military person. I grew up in the military. I went to Nigerian military school. I went to the Nigerian Defense Academy. But you don't have to be a military person to know that if you send out your troops without weapons and without defense, they will be slaughtered. And in my opinion, I feel, with all due respect, that when all we give them, children with sickle cell, all we give them are just folic acid and antimalarials without considering their immune system. We are leaving them defenseless and exposed. And so it would be helpful to not only improve their immune health, but also improve their nutritional status. That is a challenge, especially for those in remote areas. So we're left with dealing with the specific supplements. So some of the things that we're proposing, we have already, let's go on to this slide. We have already acquired the supplements for the study. We've approached the government, we're approaching state governments like Lagos State and Ekiti State and Ibadan to say, let's do a 6-month project where we will use this particular supplement at the top. It's called Ace-Manin. It is an extract from the aloe vera leaf gel, which has been used for centuries as an immune support supplement. It's used for gastric problems, it's used for skin problems as well. But basically what it is a polysaccharide that has been shown to improve immune function. I don't want to use the word boost immune function because the immune system has different functions. And COVID-19 has proven us that sometimes you don't want a boosted immune system. You want a well-regulated immune system, because what we know is that a lot of the things that have killed people with COVID-19 is an over-stimulated immune system. As a matter of fact, when we're doing this test run with Dr. Gladys, a white person, I was doing it in a coffee shop, and the white person thought we were talking about COVID-19 when we're talking about the immune system and vitamin D and vitamin C and zinc. Basically, it's the same principle. We're not sharing anything new here. Basically, the same principle that we've seen, that the same supplements that can be used not to treat a disease, but to improve function of the immune system. And we've been using Ace-Manin now for over 5 years at our center, and the results have been quite remarkable. We now want to collect the data so that we can use this. So that in the healthcare professionals around Nigeria and around the country can consider, we're not saying they should use any specific supplements, but for sure, consider using things like vitamin D, vitamin C, and zinc, which have been shown to be safe, and which will help to improve immune function. The reason why we're using Ace-Manin is because we have access to that. The company has agreed to provide it free of charge. But of course, we have to pay for the rest of the research, everything that goes around with the research, and hopefully we'll be able to start it with the permission from the government, the state governments, or the federal government. So again, thank you for listening. The goal is to have healthcare professionals consider using safe immune system supplements in addition to folic acid and antimalarials. so that hopefully we can reduce these terrible mortality statistics.
Thank you very much. That is a different concept, and that's the topic of our program today is concept. Please, we said we're going to take questions at the end of it. Thank you everybody for speaking. And I know that we have quite a few people online. If you have questions, can you type them out?
Good afternoon, all.
Good afternoon.
My name is Funsho. I'm Ore-Tayo, Funsho's dad. I joined from Lagos.
Thank you for joining.
It's a pleasure. It's a pleasure. I'd like to ask about stem cells. What are the chances of stem cell treatment being effective in the treatment of sickle cell disease? Thank you.
Take that. Stem cell research in the United States, both in pediatrics and adult, has been very successful. Nigerians have gone other places to get stem cell transplant. The issue with stem cell transplant is also compliance to avoid graft versus host disease. If you're compliant, it works. If you're not, then you get complications. I know someone in the talk mentioned about stem cell transplant being started in University of Lagos. So that's an opportunity for patients. But again, we have to be mindful that about the side effects of transplant. It has about 20%, 10 to 20% mortality rate. So here the protocol is very rigid. You have to have a sibling match. So you cannot have non-sibling donor transplant. They haven't studied that on sickle cell patients. So because of the unique population we are, we also encourage individuals that are SS or sickle cell trait or AA to get their blood samples donated to the blood bank, so that if anybody matches, then you can donate your stem cells.
In addition to that, I know that we have what they call haploid. If you are not a true match, they can do a haploid for you, half. And some people have gone to try and do a quarter and also to use cord blood, but those ones have not worked. The other thing that they are doing is what they call non-myelosuppressive agents that will decrease the chances of having the graft versus host disease. There's a lot of research being done and even gene therapy for sickle cell as well. But these ones are, once you match, the greatest thing is to have a match or a half match. Those ones have been very successful. But outside of that, it's not readily available to people who don't have like a sibling, and that. So that's the problem with the transplant.
Yeah, the half match is usually one parent. And we have a few patients at Howard that did their haploid and they worked and they've been doing very well post-transplant.
Speaking of matching, I took my sisters to NIH as well, and they said they weren't a match. So,
yeah, I have had several of those cases that have come from Nigeria and sent their samples and their sibling samples to, unfortunately, they are not a match. So it's sad, but the more, if we can get lots, the thing is, the Nigerian team, another thing they can do is start collecting samples, do bone marrow drives. I know it's a lot of cost, but that is one area that we're trying to push, see if they can get a grant, even an ASH grant, to start collecting samples so that they can go into the bone marrow bank. And Nigeria, because we are kind of a homogeneous society, country, because culturally, and is an area that is of interest to me to see, because for example, I have one patient that the mother is full match. So that is how the homogeneity is in Nigeria. So if we get lots of people donate samples to the bone marrow registry, then probably you might get non-sibling matches, but because they're from the same ethnicity, things might start changing. So I encourage everybody to, if you're here, donate your blood for the bone marrow registry. Even if you're in Europe, it's all the same. Because I could be called. I've been in the registry now for over 20 years. I still haven't been called.
We have a donor registry in Nigeria, which is funded by some people. But obviously funding can never be enough. Yes, we should get more funding. And it's based under Professor Cheney in Enugu. So have a lot of prospective donors on that donor registry as of.
But nobody has matched. That's sad.
Well, I'm sure they do. They do get patients who get a match from the donor registry.
So the other thing that we can do is blood transfusion, blood donation. Black people, we are Black people, we should donate. We cannot mix because of our polymorphism. We have a lot of different variations. So we should encourage everybody that can donate to donate blood.
Well, what are the prospects of this cord blood? Because I saved my blood too, but
It's not feasible for now.
okay. Because I've been banking them for years now, so.
It's good to bank them. You never know. Yeah.
Okay.
But see, you were fortunate enough that when you banked yours, you're not paying for it, right?
Well, initially I signed up, it was, well, no, Shady Grove Hospital, no, I wasn't paying, but initially they wanted me to pay, but no, I'm not paying right now.
No, yeah, for sickle cell patients, you don't, here in the US, you don't pay for it, so which is good. Some other people have theirs saved, but they're paying for it. So, which is fortunate. Here in the US, the blood, if you want to save your cord blood, you can save it under the program, so you won't have to pay for it.
For sickle cell, this is a great day for us.
Dr. Lassum was my family doctors from back home. I believe they joined as well. Darian Lassumbo, Dr. Shadia Lassumbo, anybody like to join in, chime in? Questions? Dr. Hafiz Misa, that's my cousin, is also a doctor from Nigeria.
Yeah, we don't. Oh, and the other thing I would like to talk about, are you with us, Dr. Onyike?
Yes, I am.
Hello. So we were actually going to talk about, because we have a few more minutes left, to talk about some of the management of the complications of sickle cell disease. Dr. Onyike is, as you know, our president of the DMV, and he's also the orthopedic surgeon who is well known here, as well as in Nigeria. And in fact, I don't know if this is HIPAA or not, he has a lot of sickle cell patients that he has treated. Oh, you can give us a few words about avascular necrosis, because a lot of young people, normally in orthopedics, they don't like to do hip replacement for young people. But for sickle cell, is a different entity, yes?
I want to say good afternoon to everybody, and I want to commend Dr. Onojobi and the rest of the panel. I missed parts and pieces of it, but the pieces I caught were excellent. So I think you've done all of us proud in putting this together, and I think it's very useful information for all of us. The session has been recorded, so those who missed it will have an opportunity beyond today to see it later. Having said that, the orthopedic manifestations of sickle cell are fairly extensive. Recently with COVID, there's been this sort of dramatization in the media that COVID is such a unique phenomena because it affects so many different organs. And one could argue that sickle cell is even more impressive than that in the way it affects so many organs. But perhaps no more disabling or devastating of that is what it does to the joints, particularly in young people. So the data is very variable from community to community, and there are no good endemic studies that I have seen in Nigeria. But looking at other clusters of large Black populations in Brazil, France, and the United States, somewhere around 12% of patients below 21 years of age will have a vascular necrosis of the femoral head. When this happens, it can result in gradual deterioration of the joint eventual destruction of the joint, and disabling pain. Until recently, there was no good treatment for that because it was a progressive deterioration that can become crippling. Probably over the last 25 to 30 years, the ability to treat those problems with joint replacement surgery has gotten better and better, and has gotten to the point where that has become the gold standard for treating the problem. It's always one that we still approach with some degree of conservatism because these patients are presenting early. But in my own hands, I've treated over 20 patients less than 18 years of age who've had joint replacement surgery. And the reason is that it works very well. It's dramatic. Patients come from a situation where they can barely get around. In some cases, cannot even sleep at night. The surgery, if it's done properly in the right hands with the right material, completely eliminates the problem. And so that's what we are able to offer patients here in the United States and also in Nigeria. So we've extended that ability to treat them in Nigeria as well. It still remains a multidisciplinary approach because some of these patients are at risk of complications more so than the typical patient who undergoes joint replacement surgery. So I think I'll end there. I mean, as far as orthopedics goes, that's probably the biggest component of sickle cell care. We do see osteomyelitis in children. We're involved in treatment of athletes. There are some fascinating discussions on management of the athletic population that I'll be happy to talk about in a different opportunity. But I'll stop here and just say that to conclude, a lot of these patients, as many as 12% under 20 years of age, and up to 50% by the time they get to 35 years of age, will have osteonecrosis of the hip, resulting in pain, significant limitations in daily activities that has no other solution but joint replacement surgery. And when done properly, is a game changer. Thank you.
Just to add one or two things to that, Dr. Onyike, excuse me, is one of my doctors. I've seen him, here in the States and also in Nigeria, in Lekki area, right in front of are you still at that location from the hotel nearby?
We're in VA now.
Yeah, no, okay.
And off Idejo Street.
Okay.
Yeah.
And I also had vascular necrosis of the left hip. So I had a total left hip replacement done in 2013, I believe. And then it wasn't done properly. So I had to, have a revision. I had to, had to have it redone in 2014. So yes, I mean, it's great. It's helped greatly. It's alleviates the pain, less painkillers, basically. But yes, it's good. It needed to be done. So.
And I'll quickly touch on that to say that it's more complicated to do a hip replacement in a sickle cell patient than the general population patient for a number of reasons. I think the anatomy is distorted in the bone itself. And so when people don't recognize that, they can get in some intraoperative trouble. And so it does require a setting where the appropriate instrumentation and skill are both available. And sorry to hear that your initial surgery did not go well. I already knew that, but my advice to anybody seeking this surgery would be to apply appropriate due diligence and put themselves in the hands of the right expertise.
Thank you, everybody, for contributing to this great day. It's a nice thing to know that doctors left their time, patients left their time, family members left their time to talk about sickle cell disease. This is a beginning, and it's something that we really need to help ourselves so that all the people who are involved can help us to help our patients.
Sorry to interrupt. We have two questions in the chat.
Okay.
One question says, Nipristan, is it a successful drug for sickle cell?
Professor Akinola, can you take that?
That is a very difficult question to answer. I'm sorry. You see, the data we have is more or less no data. So yes, people have been taking it, and a lot of different reports have been given. Some people say it works for them. Some people say it doesn't work for them. And so it's a combination of several compounds, actually. So it's difficult to actually say because a properly conducted clinical trial is not done, not in Nigeria anyway.
So we can say it can be used as a supplement then.
Yes, you can use it as a supplement.
As a supplement,
then
that would be worthwhile to do, because so far I don't think they've had any deaths or anything with that.
Oh, no.
Okay, so it might
it's safe to use, there's no doubt, but it's the response of patients that's variable.
Well, speaking from personal experience, I have used it. I've used it in the past when I was in Nigeria, and brought some with me in the States before, I guess, the rights were sold to the Indian company, and then I guess it's back in Nigeria now. So it did help back then, before I took Auricula and the others, it did help. So I actually didn't know it was back in Nigeria. So I guess I'll see how I can get some again and take it. We have another question. Yes.
Yeah, this is Dr. Bolondero. I have a question on, I don't know if anyone mentioned this, but in passing, I've had calls to, and I'm sure we all have, advise people, friends and family and all that. And then there is a knowledge gap in terms of advances, in terms of prevention of sickle cell disease in people who are married and they happen to find out that they are both sickle cell genotype. They both have the sickle cell genotype. I don't know if somebody wants to talk a little more about ICSI, that's intracytoplasmic sperm injection, or some other newer modalities that could be done in such people who are like, well, does that mean we have to have a divorce? Does that mean we can't have kids? Those kind of things. I would love for someone to give a little more information about that.
Well, I can say one or two things on the personal side. I'll leave the doctors to handle the medical side. There was a lady that I was involved with back then. This was back in Florida, in Tampa, and her mom more or less prevented us from moving forward with the relationship because her dad has sickle cell, and they obviously knew I had sickle cell, and there was the probability that our kids will have it. So we sort of ended the relationship because of that. Of course, we talked about, she's a medical doctor now as well. We talked about different, we knew that time, with time, things will get better in the medical world and there'll be, quote unquote, a cure or different remedies, but that the mom wasn't happy and, they didn't want to take a chance. And, that was that. But I believe there are some remedies. There's the prenatal part that can be addressed. So Dr. Onojobi, over to you.
Okay, Dr. Onyekwere, do you want to take that or?
Okay, so in terms of relationship and things of the heart, it's left to the individual, but the key thing is education and well-informed. I've had couples, we have several students at Howard University, even some medical students, couples that have sickle cell trait and they end up having a child with sickle cell disease. The issue with genetic counseling, you counsel them, but it's still of the heart. If they want to, depend on the location too. Here in US, the newborn screening helps. They also do prenatal, but the prenatal is a 50. Nobody will touch you if you say you're not going to abort the child because there's a risk when you do the testing. However, they have good prognosis now. I was with penicillin, close monitoring, and all hydroxyurea and other drugs. They can live a normal and relatively normal life. But back home, we don't have enough genetic counseling based on the number of children born with sickle cell disease or number of children born with sickle cell trait. So education becomes paramount, that we have to educate our communities about sickle cell disease. And how will I put it? It's not a death sentence disease. Because some parents, they have a child with sickle cell disease. That means, oh, that child can't do anything. Sickle cell patients have thrived in Nigeria, but it has to be, the parents have to put the time working with the doctors, reading, and that, making sure that the kids are hydrated and they understand that their chances of surviving and living a normal, relatively normal life is pretty good if they take care of themselves. But where we don't have that, then you have kids dying, infant mortality. Death comes with infant mortality because they do succumb to severe malaria and die from it, an infection. So education, and knowledge is very important in Nigeria.
In terms of gene therapy for sickle cell patients, in fact, in the United States, it is not acceptable for us as providers to tell two sickle cell people not to marry. We have to give them counseling, and then they will make their decisions, and then we will help them to move forward, whatever their decisions are. That is the standard of care. But when it comes to gene therapy, in terms of alternating the thing, it's very difficult because sickle cell, as you know, is the first disease in the hematology that actually showed us that there's a nucleotide change. It was the first disease, and we are still where we were when they found it. Meanwhile, cystic fibrosis and other things have gone into gene therapy in different ways. The question with sickle cell is that there is an alteration, a mutation from the valine by glutamic to valine, and that changes the whole consequences of the whole thing. So it's difficult to take a sperm and then look at it and change that dynamics. So that is why so far, I'm not going to say any more than that in terms of science. So, but if you have hypospermia, where you need a lot of concentration of sperms, you can put them together and then inject it into the ovum because you want quantity. But in this is gene, and even that is still, I'm sure it's ongoing, but right now.
Yeah, I want to bring that up because I had a family, there was something I was personally involved with, and this was back in New York, and maybe about 10 years ago, and in Manhattan, and then spoke with the gene therapists there. They have therapy where the pre-implantation genetic diagnosis, where they will take the sperm, and then and I read the papers about it. Actually, there was a lot of publications about it. So I was trying to see what has evolved. There will be pre-implantation genetic diagnosis on the sperm. They will test the sperm and figure out which ones actually are non-carrier sperms, and then do an intracytoplasmic sperm injection separately, then implants later. I actually spoke to a few. What is it?
That patient is not SS. That patient
will not be SS. Yes. So exactly. The parents are both AS.
Yeah.
The parents are both AS.
Then you can selectively. That's what I was telling you. Either in hypospermia or where you have small, so you can get that particular one that is not SS. So I'm talking about SS patients right now.
Oh yeah. SS patients, I think that would be
yes, you can do that. That's what I told you. You are not supposed to tell an AS not to marry.
Yes.
You can't say that. You counsel them, you give them all the options that are available. But when it comes to SS, for now, we are still on it. And that's all I can say.
Yes.
Good afternoon. My name is Abiola Gumbi. I'm calling from Lagos.
Okay.
One of your colleagues in the US had sent this to me. Incidentally, we had the Sickle Cell press conference in Lagos. My first question is there any collaborative relationship between you in the US and the Sickle Cell Foundation in Nigeria, in Lagos? I just want to know if that's available. And then secondly, if it's not available, is there a possibility that can be done? And I'm asking that, it's an effort I've been involved in for 30 years with Professor Akinyoju. And the reason that we set up that was a WHO recommendation that a research institute is required in a country that has the numbers. So first, is there a collaborative effort going on? Secondly, if none, is there a possibility that we could advance that? Thank you.
Thank you very much for your question. I think I have someone who has worked with Professor Akinyoju in the past in Nigeria. I might just ask her, Dr. Onyinye Onyekwere, are you still there?
Sorry, I turned off my video because I really can't hear you. It's not clear.
Okay. So she was asking if there's a collaboration between the Sickle Cell Foundation in Nigeria and the Sickle Cell here in the United States. And if not, why not? Or is there any way there can be one?
There is, actually there is. There are various ASH grants in Nigeria now. With the Sickle Cell Support Society of Nigeria, the ongoing newborn screening in Abuja and Ahmadu Bello University. And they have multi-center study. Also, some are looking at hydroxyurea impact. And with Ghana and other countries, sickle cell centers in other parts of Nigeria. So there is ongoing research and ongoing collaboration with Nigerian sickle cell centers. But with Akinyoju, I don't know, because Dr. Akinyoju kind of stopped coming to ASH and all that. So I used to collaborate with him long time ago, but not recently.
Okay, I went off for some time. I had internet issues. So I'm sorry, I didn't hear most of those answers. We actually have a national director. She's a public health practitioner. I'm a lawyer, by the way, so I'm not a medical person. So a lot of the discussions have been really above me. But we do have Mrs. Annette Akinshete, who is currently the CEO of the center, and she has wide powers. The board has been extended. So there's opportunity for collaboration, and something that I'm in Nigeria, so something that COVID has brought to the fore, even within the Nigerian community and Nigerians in Nigeria, is the need for collaboration and synergy. And it's been our lack of taking on that space has been identified as one of the reasons we're having serious issues in the country. There are pockets of effort, but we're all reinventing the wheel, and we need to move beyond that. We need to enforce collaboration and synergy. I'm sorry, I didn't hear much.
Nigeria,
I'm having internet challenges. So I don't know, that may have been, you may have spoken, but it went
so off. Nigeria, 6 years ago, developed a Nigerian Society of Hematology and African Society of Hematology. Likewise, the last 4 years have been in collaboration with other countries in terms of research, and they have had ASH grants to do studies in Nigeria and other parts of Africa. So I'm not sure, are you guys in connection with the Sickle Cell Support Society of Nigeria?
We actually have the bone transplant unit that has been commissioned in Louth. And part of the reason, because I'm a lawyer and I got involved very young. And the reason I got involved, I was a rookie then, was to ensure that we had a facility that could work and research could be carried out. Initially, the land that was given to sickle cell, Professor Akinyoju, was meant to be far away in Lekki. But in order to have this long-term view on things was why he took the land opposite Louth, so that there was already a teaching hospital that you could collaborate with. And the CMD of Louth is on the board of sickle cell by virtue of whoever is there. The Minister of Health has a seat on the board of the Sickle Cell Foundation. And there's a lot of collaboration going within that space called Nigeria, on different efforts, pockets of efforts across the country, that the sickle cell clubs that have been in existence for over 40 years, the foundation, like I told you, started, that effort towards building the foundation. I know I got involved, and that was the reason I was involved, to ensure that the legal scope was set up right. And the firm that was approached there was the firm Ajibade, where I worked, at that time. So it's been a well thought through. And sometimes when you're talking strategy and you're building foundations, it can appear slow. But please, for those who are interested, I would suggest that you just reach out to them again. I mean, I'm on the board, like I said, but we have a national director, and you can reach out to the Sickle Cell Foundation, and let's see, because I mean, I'm excited by the discussions that I heard. Some, like I said, above, but I mean, we're there. And the question about marriage, they actually, I mean, even state governors will tell you, they mustn't marry SS, mustn't marry SS, AS mustn't marry this, you know? So those are things that we always try, we're trying hard to correct. But as you try to correct as well, you need to be mindful of parents who actually may have sickle cell children and family who've come in touch with that and some of the issues that they have, you know? So, but collaboration, synergy, that's what started my point. Thank you.
My question is, are you guys in collaboration with the people in Abuja or Amadu Bello?
This is in Lagos. The Sickle Cell Foundation is in Lagos. Yes, I'm
I'm talking about the collaboration within the country.
Oh yes, definitely. You know, across board now, the aspect, in fact, more so now is what I said, since COVID. Some years back, everybody was doing their pockets, you know, I'm the one, I own it, I'm the master and the CEO. But we found out that it's not working, you know, and that needs to change. And there's openness to change, but it has to also be enforced and embraced, you know, so that's what I'm saying. You know, all these opportunities, we are open. The Sickle Cell Foundation is out there, open, you know, for every Nigerian. That was the concept. Like I said, I was the lawyer involved as a, as a young person who dropped the agreements, dropped the bylaws, went through, got tax exempt status, ran through it all, did the negotiations with loot on the land. I was very young. How old was I? 20, 30 then, 20, my 20s, you know, early 30s. And with the WHO, we were working with the WHO as well, because they had said, set up a center. You need a research center. You know, legislation, obviously, we're moving to try and get legislation as well, you know, but there's so much that, you know, they can do within that space.
So it's a very interesting topic and very interesting outcome. So I don't think we should leave it the way we are now, because we know that according to Dr. Onyekwere, she is in touch with a lot of people in Nigeria who are doing a collaborative study, but I think we have to merge, find a way to merge together.
Thank you.
I think ANPA, which is doing this presentation, we can work within that and kind of set up a committee and see where everybody can be a cohesive team. And so I would liaise with Onyekwere and with you, if you can give us your information. So if we can get together, if you can send an email, and then we can go on from there and see what can develop. Abiola. So I think we can move forward on that and see what can develop, because this is where ANPA is really keen on making sure that not only do we as a diaspora, not only do we do things, we have to move forward. And that was one of the reasons we also brought Dr. Ajibade to this forum as well, so that, you know, everything will be collaborative and do a better job. So we have
Dr. Onojobi.
Yes, ma'am.
There's a question about sickle cell HC and comparison to SS. And SS, somebody say, kindly comment on HC and how it is similar to SS.
Yeah, SC and SS.
Somebody just put a question.
So the question about SS, like I said, a C, hemoglobin C, it's different from, okay, let me start. When you look at the genotype, like they presented, Professor Akinola, can you take that, SC and SS?
The SS mutation is the substitution of valine for glutamic acid, whereas the SC, the C mutation, is the substitution of lysine for glutamic acid. Now, you find that in the process of polymerization, the C gene does not actively take part in sickling. It behaves as if it's an A. So you find that this is one of the, what we call sickle cell disorders. And this is defined as the inheritance of the sickle gene together with another unusual hemoglobin variant. So the C gene is an unusual hemoglobin variant, but there's no sickle. But it's been found that there's a sickle, HBC halum. C halum is found to sickle. So, but if it's the C, which is not C halum, it does not take part in the sickling process. So which means that anybody who has C is likely to have a less severe disease. However, there is an association of hyperviscosity syndrome in the SC individual because they have steady state hematocrit that is higher than what we see in the SS. And this causes, and we know that there's a relationship between the blood viscosity and the level of the PCV, the packed cell volume. So the higher the packed cell volume that you get in sickle cell SC, the higher the tendency to have end organ damage as a result of sickle cell SC. And this causes them to have a lot of complications like vascular necrosis, eye problems, and things like that. So yes, it's supposed to ameliorate the severity of the sickle cell disease on one hand, but on the other hand, it's associated with other complications. So it is a double-edged sword phenomenon whereby you think it's a milder disease, whereas they come back later in older age with very, very severe complications. I hope that's the question.
There's another question here. Thank you for that. I appreciate it. Dr. Onojobi, there's another question. Someone is asking about, Dr. Darian Lassenbo is asking if you can elaborate on CRISPR Cas9 technology for sickle cell patients. Are you familiar with that?
Are you still with us?
Yes, I'm here. The CRISPR technology is a technology using gene editing. So it's a process by which some viruses are used, retroviruses are used to carry the normal, the usual hemoglobin gene to replace the mutated gene. And it's a form of gene therapy. And it's a new principle, and it was given the Nobel Prize, I think not too long ago. I think it was last year. 2 ladies won the Nobel Prize on account of this. I think that's all I can say for now.
That's something that you think that I would benefit from, or what do you think?
Well, it's gene therapy, and gene therapy is still in the clinical trial stage.
Okay.
And we've been hearing certain complications coming up. So some gene therapy clinical trials have been put on hold for now because of these complications. So yes, once the problems are sorted and corrected, then maybe there's a way forward. There could be a way forward from it.
So any more questions? I think we're done for today. It's been a very interesting and knowledgeable profile for sickle cell disease. And I think it's a great day for sickle cell disease too. So we'll be looking forward to progress being made, especially Ms. Abiola talking about collaboration. That's a way forward. And for everybody else, we'll look at the future concepts of sickle cell disease. Thank you all for coming.
Thank you very much.
Thank you, and happy.
Thank you to the panel.
Okay, thank you very much. Nice having been here. I'm have to go and say thank you very much to the gentleman that sent me the link. Thank you, and best have a lovely day.
You too.
Bye.
Bye. Bye.
Bye.
Bye.